Apparently this one is working. Hello, good morning, everyone. Happy to see you here again this morning. Hope you are, um, you know, knowing better each other, so sharing and having a great time here in the program, and obviously learning. That's that's our goal, right? So we are very happy to have here today to talk to you, our friends from the uh, World, World Health Organization. So WHO is in official relationships with IDF. So it's obviously fundamental to be, with WHO in order to reach the globe, as you know. So I will ask them to introduce themselves, James, Bianca, and Ida, who, by the way, I have been interacting a lot in the past, I don't know, maybe two years especially, right? Thank you very much for being here.
Thanks a lot, Mark, and thanks a lot, all of you, for giving us the opportunity to talk more about our work and have a chance to meet all of you. My name is Bianca Hemmingsen. I'm a medical officer, having the technical lead of the diabetes work in the World Health Organization. And I have two colleagues with me who also contribute to the diabetes works, Ida and James. So I think maybe the two of you could give an introduction of you.
Yeah, sure. I don't know if I have a mic, but I'll just talk really loudly. So I'm James Elliott. I'm project manager of the WHO Global Diabetes Compact. I'm also a person living with type 1 diabetes. In previous work, I've worked with Doctors Without Borders, MSF. I see there's people here from Lebanon, so I've been to Lebanon before, Becca. I've also worked in government in Canada, and I was a board member of T1 International, which was actually founded by a young leader herself, Elizabeth Feister. So I do a lot of diabetes work. Nice to meet everyone.
Hi everyone, my name is Ida. I am a person living with type 1 diabetes for 40 years. I just had my 40th anniversary, so congratulations to me. I'm based in San Francisco, but I'm supporting the team in Geneva that is really reaching out to people all over the world to learn from the lived experience of many different conditions in addition to diabetes, such as cancer, respiratory diseases, and mental health conditions. So it's really an honor to be here, and thank you for having us. And my background is primarily in the NGO sector, in the international NGO sector. I've spent a lot of time working across Asia, and yeah, happy to take your questions today. Thank you.
Yeah, and we have all prepared like a few slides for today. And we'll talk about the global commitments that we have in the World Health Organization, but also talk more about how to engage and how to keep up to date with the work that we are doing. So last year we had a diabetes resolution, and to be honest, before I joined the World Health Organization, I did not really know what a resolution was, so I'm not just to briefly mention it, is like an agreement that the member states, like the countries, they do. It's not like a legal one, so they cannot, like it's not by law, but it's like agreement they all think they should prioritize. So the resolution last year was on diabetes, and the title is there. I don't know if you can see it, otherwise I'll read it aloud. It was reducing the burden of non-communicable diseases through strengthening prevention and control of diabetes. And this agreement, it gives a lot of demands to the countries, things they should do in order to prioritize diabetes, but it also gives a lot of recommendations or commitments that we should do in the World Health Organization. There's a total of 8 commitments. I'll not go through all of them, but just to mention an example is like provide guidance for diabetes management in humanitarian settings, increase transparency of markets of insulin and diabetes medicine in general, including technical or innovations and technologies for diabetes. And one very central thing that was also required from the World Health Organization was the development of targets. And I don't know if you've seen these targets before, but it's coverage targets that the member states has agreed on should be achieved by 2030. And it says that 80% of people with diabetes are diagnosed, and 80% of people with diagnosed diabetes have good control of glycemia. 80% of people with diagnosed diabetes have good control of blood pressure, 60% with diabetes of 40 years or older receive statin, and finally 100% of people with type 1 diabetes have access to affordable insulin treatment and blood glucose monitoring. So this is the targets that member states should achieve, but it's also targets that we should facilitate member states to achieve through supporting products and provide guidance to them. Oh, we have questions already. Yeah, please, there's 2 questions. Yeah, you can, I don't know, should I just pick and choose, then I'll take the one in front of me to start.
Hello, I'm Leonore from France. I wanted to know if you can give us an idea of where we at now regarding those numbers. Like, where do we come from? Are we at 50 and we want to go to 80, or really far away?
Thanks a lot for the question. This is like global targets, so it means that it would be very different from country to country where they are with the targets. And one of the challenging with the targets is that we should monitor them. So we need to know where we are and where we're going. So in order to do that, like I mentioned, we have to provide products, like technical product that should guide member states. So one thing we will develop during the next year will be a global monitoring framework for diabetes, for example, to help monitoring of these targets for the member states. It's very different from country to country how good data they have. And for some countries, like, this might seem not very ambitious, and from some countries this is really ambitious and very difficult to achieve. And it was some of the critique when we had the consultation with the member states. Some of them said this is simply too difficult, and others said we already do that even better. So it's like a global target, and some of the countries, they have like made intermediate targets in order to, because it's, for some countries it's very ambitious, but still when we made this target, it was like in consultation with member states and with experts. We still think they're achievable despite being ambitious. So it's just, it can still be made. Yeah.
Sorry, I've got the mic, I'll pass it to you after. So first of all, I just want to say, we had a discussion about this in South Africa, and we really appreciate the focus and the push on diabetes and to have these targets and goals. But I still just feel that, especially in lower to middle income countries, is this realistic in any sense for those countries? So what are we doing for the lower to middle income countries that, if I look at these 5 goals, none of these are achievable in South Africa by 2030, if I'm being honest. So what can we do in our countries where we feel like these are not achievable at all? It just kind of feels like, wow, that's super ambitious. It feels.
Yeah, thanks a lot. And I'm very aware that these are very ambitious, and it's like it's not 10 years, but 8 years target that we have to achieve these. So we need to already act now and not let the time go. So that I have actually not taken the list of all the products that we have planned to provide member states. But beside making these products, we also visit member states and help on the ground or give advice on the ground, like what could be done concretely in different countries. Because there's a huge gap in a lot of these targets, at least in several low and middle income countries. Yeah.
Yeah, it's a fair point. I think also some of the inspiration of this is, again, from the HIV side. So in HIV, they had the 90 targets, which, again, very ambitious, and it's a guide stone. I think also specific to South Africa, there are a lot of good South African advocates at this conference. So Patrick from University of Pretoria is here, also Bridget. So very much encourage you to reach out to them, and we're here to help, and we'll get into a little bit how you can keep informed with us.
Yeah, and to mention these targets, is not, I know they are difficult to achieve, but targets also have the mean by increasing accountability from the countries. They will be measured now on this. So they need to, or they at least they had committed to do some progress and try to achieve this. So it's a kind of showing commitment, both political, financial, but also prioritize diabetes. So despite it might be difficult to achieve, it will still have some political impact. Yeah. Yeah.
Hi, Sabina from Slovakia. So I would like to ask, you mentioned that every country has the numbers are different, depends on the country. Do you know the exact numbers for each country? And if you do, how do you manage to monitor it? Is it only up to the countries? Because how do we know the numbers are real and it's not just the way they present it?
Yeah, and that's yeah. Thanks a lot for the question, because of course it's a problem like how to monitor it, and that's why we are going to try to help countries with it, with making like a monitoring framework that can be adapted into country context and to help monitoring the targets. Because right now it's a huge issue just having this registered in some countries at all, like even have the patient both have a diabetes or not even, like you need to have some kind of system to monitor the people living with diabetes in order to do the registrations.
Can I have one more question?
Yeah, please.
Do you have any plans installed how to achieve these targets?
Do we have any plan to achieve the targets?
What? Oh, sorry, because I couldn't hear you, so I just, how to achieve the targets?
Yeah, if you have any plans installed.
Yeah, there are like several, in this resolution, there are several, or this agreement between the countries and the World Health Organization, there are several means by what we should do to achieve these targets. For example, for people with type 1 diabetes to have access to affordable insulin treatment and blood glucose monitoring, some of the things that we are committed to is to increase transparency of the markets. So we have dialogues with the private sector, for example, to make them to do commitments. We try to facilitate the pre-qualification of insulin to, it's like pre-qualification, it's like a World Health Organization term, so just to explain it briefly, it's to ensure that quality-insured insulin will be made available. So the reason for doing that is to increase the options and not only the three major players on the insulin market currently. And this is like the different initiatives we have. We're also currently undergoing the same pre-qualification of HbA1c and glucose monitoring. So it's just some of the things that we are doing in order to promote us going in the right direction, but still we need it's not only us to do it, which also will come in another slide. We need member states to help, we need private sector, we need civil society. Like even though it's an initiative by the World Health Organization, we need a lot of people and other organizations to contribute, because we cannot do it alone.
Thank you.
Can I go to the next slide? Yeah, good. Perfect. And it was last year in May that we had the resolution on diabetes, or this agreement, and it was very timely because just a month before this agreement was made, we launched the Global Diabetes Compact Initiative in the World Health Organization. And the objective of the Global Diabetes Compact is written there. I can read it loud if you one in the back can't see it, but it's to reduce the risk of diabetes and to ensure that all people who are diagnosed with diabetes have access to affordable and quality management. And this Global Diabetes Compact Initiative, it was launched together with the government of Canada, and it had a lot of high-level representation with head of states, of ministers of health, who all committed to prioritize diabetes. This Global Diabetes Compact has 6 work streams, which we work through, all of us, in order to achieve the objective. The work stream 1 is access to essential diabetes medicine and associated health technologies. And I just mentioned some example of what we already have done there, or what we are doing there. It's, for example, having the pre-qualification or ensure quality assured insulin to be produced, and access to point of care test of HbA1c and glucose measuring devices. The next work stream we had is technical products. Technical products is like guidelines. And to mention some of the technical products we currently are working on is, for example, the global monitoring framework, like how to monitor the targets, but also to For example, we are currently making guidelines on insulin treatment in low resource settings is another example. We are also looking at the tuberculosis and diabetes management. So there are several technical products that we are currently working on. Workstream 3 is prevention, health promotion, and health literacy. And James, he has been leading some of the work there that he will present actually later today in a poster, but also later in the slide.
12:30.
The workstream 4 is country support, and this is actually extremely important because that's where we should do the difference, really. It's at the country level. So the country support is like we are adapting the guidelines or our work into country context. We are going to the ground to provide advice, like how can it be improved. And we also, if the country has a question of any kind, they can give it to us and we do our best to guide them. The research and innovation work stream, it's a work stream that currently are looking at the research gap for diabetes, for example. What should be prioritized? And another thing that will come soon, it will actually come later this month, there will be a call for innovation in low and middle income settings focused on NCDs, which also could include innovations for diabetes. Workstream 6, it's a governance strategy and partnership, which is extremely important because, like mentioned before, that even though it's initiated by the World Health Organization, this initiative, the Global Diabetes Compact, then we need contributions from several sectors. And actually James, who's next to me, he's leading a lot of these engagements, so maybe James, you should tell a bit more.
Okay, so we basically have different platforms for different sorts of stakeholders, and we do this to make sure that every stakeholder has a voice here. So individual patients, we run at least annual focus groups. So those will probably be coming out in the spring. We have a newsletter, so you'll see word on that, but everyone's welcome to apply. We also have the Global Diabetes Compact Forum, which is our way of talking to civil society. So if you're part of a charity, you're part of an academic institution, any non-state actor. The only reasons why we couldn't talk to you is if you have links with the tobacco or arms industries. Otherwise, you can apply for membership for the forum. And it's a way, we have over 90 different organizations now, all the way from super high-level universities, all the way to people doing cool work in Malawi. So we have 3-hour meetings for over 2 days, twice a year. And we also have like a WhatsApp group and a LinkedIn, so people can kind of share like, this is what I did for World Diabetes Day, or I've got a grant coming out. It's a pretty good system. We also have the Technical Advisory Group for Diabetes, which is our mode of engaging with academic experts. So some of them are here at this conference. It's currently chaired by Professor Amanda Adler of the Oxford University. Private sector dialogue.
Oh, if I may, just very important for this technical advisory group, we actually have 2 persons living with diabetes as a part of the expert in the group. So we say it's technical advisory group, and yes, but we take lived experience as an expertise as well. So it's 2 of the seats is currently Apurva Gumper and Daniela Roches, who has
who are both here.
Yeah, they're both here actually.
Yep. So it's, they're experts in their own right, but we also thought it's important that they themselves, we have certain allocations for experts who also have lived experience of diabetes. And the other thing about the tag is it has to be balanced by the different regions of the WHO. So there has to be certain membership from Africa, certain membership from the Americas, certain from Europe, certain from Asia, and we also have gender balance as well. There's the private sector dialogues, which as mentioned, these are a little bit less transparent and less open, just by design. So our colleagues, Bashirinos, he's in charge of that. You also see some recent news releases for some of the commitments the private sector has been making. And finally, there's the engagement of both regions. So the WHO has regional offices. So for in America, you'd be familiar with PAHO, Europe is Euro, et cetera, et cetera. So we talk to the regional offices of the WHO who have quite a bit of autonomy, also the country offices, and not me, but others do actually have conversations with the actual member states. So it's a lot of people to talk to, and it's a lot of management, and we try to make sure that the information is shared properly, and we look for opportunities that can help everyone out and achieve the targets and try to get fewer of us dying. Next slide.
Yeah,
Oh, I have it.
You have it. You're the boss now.
I'm the boss now, okay. We were talking a little bit about health literacy and language and prevention. So we embarked on quite a large, what we're calling the Key Informant Survey of people with lived experience of diabetes. So we had over 900 respondents from 54 different member states fill out a survey. It's possible that some of you in this crowd actually filled out the survey. So this is coming from a place of the WHO has realized that, one, the importance of language in terms of diseases, but especially diabetes, is an issue that we need to address. But also the WHO realizes that some of the way that the WHO has been communicating about diabetes needs to be improved. And I think personally that there's a link between, we talk about the burden of diabetes and how many people are living with diabetes. You know, the comment from South Africa, if you look at like tuberculosis, you look at HIV, there's a lot more resources out there. We're not saying there should be less resources for TB and HIV. We're saying that diabetes should enjoy at least as much resources as those diseases. And the use of language and how we talk about diabetes, we think has a direct impact on both advocacy, but also our arguments for more resources to be mobilized towards things like the target. So there's a poster presentation that I'll be leading at 12:30. I think, well, you can come get me later, but I think it's Pavilion 3, but I might be wrong. They changed it. Anyway, look us up. I think that's it. Oh no.
One more slide after this.
Okay. So we have a website. You could also Google WHO Global Diabetes Compact, and that'll lead you here. And there's a couple different ways that you can directly get involved. Send us an email. So it's gdc2030@who.int, and we'll sign you up for our monthly newsletter. So it can be a bit technical, I should say. Like, we do actually get into, like, you know, what technical products are coming out, what meetings are coming out. But if you actually want to see like what we're doing on a quite regular basis, it's probably the best way. You can also just send us an email. That's fine too. You know, it goes to all of us. Oh, there we go. Thanks, Bruno. As mentioned, we will be doing at least annual focus groups directly to hear from people living with diabetes. So we do talk to people with diabetes, but we have the focus group specifically for people who are unaligned with a non-state actor. So you can just attend as your individual person. There'll be more information that'll come out in the newsletter soon on that, but we anticipate it'll be in the spring. If you're part of an existing NGO, or you know people who are part of an NGO that has an interest in diabetes, look at the Global Diabetes Compact Forum. Meetings are twice a year. Next meeting will be in the spring. And it's very likely that we will have more webinars, more events, and more information coming out. That's it.
Yeah,
Yep.
that's it.
Cool. You can pick the questions. Do you want to?
No.
Thank you. I'm Roberto from Cuba. Thank you for this presentation. I will have a comment and 2 questions regarding the targets of the Global Diabetes Compact. I think there is a quite evident gap between developing and developed nations in order to fulfill these targets. Hence, my question will be, are they conceived mean of implementations for those developing countries that are like a little bit later to achieve these goals? Financing, capacity building, technology transfer. And the second one will be in relation with the Young Leader program. Which are the ways that young leaders can approach WHO to benefit from guidelines, not only forums, as you said in the last slide, but also guidelines, perhaps through regional offices or country offices, funding for their projects. It is available. Just if you could build up in these comments too.
Take the second. Take the first, I'll take the second.
I did not hear. I'm sorry, there was a bit noise. I'm not sure I got the first question about the targets. Could you please repeat? The question was?
I mean, are there conceived means of implementation for developing countries to fulfill these targets? Finance,
Yeah.
capacity building. These means of implementations are based mainly in public financing or involves other stakeholders' participation, like NGOs, private sector.
Thanks a lot. Thanks a lot. To reply to that, one of the things or one of the asks we have in this resolution that I mentioned, it's like to help with the financing or guide on the financing. But one thing that is very crucial, it's to have to limit the out-of-pocket and make diabetes a part of universal health coverage, because it's really needed, and it is quite expensive to do. So we need to help with the financing, or at least guide like how can it be done, and also when we do the guidelines, take cost considerations into account when we are making recommendations, of course. I think regarding the country work as such, we are already now working with some countries to make concrete plans for a period of time on how to achieve the targets. In order to make it like manageable, because it's like an 8-year project, we have like made for the countries that we are currently working with, made like interim targets for what should be done in 2025, 2027, and then we, together with the country offices and the regional offices, we have made a plan like what should be strengthened, which capacity, like training is super important of healthcare workers, but also patient education to strengthen because insulin is one thing, but it does not really get us there if people don't know how to use it, neither the healthcare workers or if the capacity also, like the health literacy of the patients also need to be followed up. So we have several plans in some countries already about how to help them achieve the targets.
And I think there was a second question about what specifically young leaders can do. I think if you're in Cuba, you benefit from a very active regional office in PAHO, the Pan American Health Organization. And some of the regions of the WHO are what we're calling regionalizing the compact. So the regional office is taking on this idea of the compact and the targets and working within the regions. And PAHO is one of those regions. They recently had a report called, I think it's called the Panorama on Diabetes. So you can look for that online, Panorama of Diabetes. There was also a webinar in Spanish, and PAHO is also quite good at being bilingual, Spanish, English, sometimes French as well.
I think Ida has something to add as well.
Yeah, so one thing I would encourage from all of you, and just to share this as a little bit of background, our team has worked over the past 2 years. We've reached out to over 1,000 people representing 111 countries to really learn from the lived experience of their conditions. Mark knows this very well. He's been championing this work and supporting us, Bruno as well, so we thank them. But one of the most interesting findings in that work is that the most underrepresented perspectives are youth perspectives. So what does that mean in terms of what you can do? It can be as simple as James mentioned, just to attend a focus group, to, if you see an invitation to participate in some type of participatory research, to really lend your voice. It might seem like a small thing and perhaps slightly disconnected from the bigger outcome that you're all hoping to achieve within your local context, but I just want to emphasize how important that is for all of us in the work that we're doing. So we need your voices as well. So any opportunity, if you join the GDC newsletter, you'll hopefully see some of that, and to really take advantage of that, to share that amongst your own communities, I think is very valuable and helpful to us in the future work, not just of the GDC, but the broader efforts of WHO related to the lived experience and your perspectives.
Hi everyone, my name is Reyo, I'm from Lebanon. First of all, I just wanted to thank you for everything that you're doing. I was a part of one of the consultations for the MENA region, and it was amazing. I loved how much the involvement of youth was encouraged, and our point of view was actually taken into consideration. We felt like we were heard for once. But my question is, after 2030, regarding the targets, so we were just talking about, and following up on some of my colleagues' questions, Obviously, it's too ambitious, as you said, for some of the countries, and they might not reach it in 2030. Will there be a follow-up after 2030 for those who do not reach it? Obviously, as you said, they will be held accountable, but you cannot hold a third world developing country as accountable as someone who has enough resources and more than enough help to reach these targets. So will there be is it something that's going to be sustainable for after 2030 with follow-ups and help to reach the targets?
To be completely blunt, then we haven't decided what to do if they do not reach it, because our goal is that they reach it. But yes, I know it will be challenging, but we still, and I know it's ambitious, but we still aim that everyone can reach it. Like that's the goal. So I know that it's ambitious, but we will do our best to support the countries to get there. So, and of course, it might be a fact that not everyone will reach it because they are ambitious, and this we will have to find out how to handle this. But for now, it's still our goal that everyone should be there.
Okay, thank you so much.
You're welcome.
If I could just add, I think also the reason why there's a compact and the reason why there's targets in the first place is because of people like the young leaders, but also, like Santé Diabète, also TU International, also Health Action International, who really advocated for, at their own countries, their own member states, for action on diabetes. And if there was not that advocacy, the Global Diabetes Compact and these targets wouldn't exist. It would just continue to be.
Yeah, I'll say before we launched the Global Diabetes Compact, we had two consultations. We had a consultation with individual experts, and we had a consultation with different NGOs and stakeholders. And the biggest ask that came from these consultations with experts and NGOs, it was that they wanted targets to drive the agenda. So even though the resolution and the agreement is with member states, it was also a big ask that we had from the civil society that we had engaged in the development.
So ask us for targets after 2030, or ask your member states to ask us.
Hey, I have another question. I saw that one of the topics that you're dealing with is the research. And I feel like if you compare all numbers of diabetes, like people living with diabetes, the cost of diabetes, deaths linked to diabetes, we don't get the research that this condition deserves. I was wondering what the World Health Organization is doing about this. And I also saw that you can influence the priority of research. Is finding the cause and finding a cure the priority, or is it still finding the new insulin, the new device, the new closed loop and everything? Because I feel like the focus has been a lot about living better with diabetes, but we forget about finding the cause and finding a cure.
Yeah, it's actually, to be honest, it's not me or the World Health Organization who decide these research prioritization. We are talking with different, there have been a survey out to different member states or people who works in the ministers of health or have attachment there to what do they see as their priorities, and also to us technical advisory group, the experts we have. And it has been shared with, I don't know how many actually, because I've not been the one leading this, but it has been shared quite widely. And I know we have seen some of the requests, and it's very different. And there are also cure for diabetes, for example, and then there's also other wishes insulin that could last one injection per week, and there's all kind of requests in the research gap.
Hi, thank you for your presentation. I'm Ricardo from Portugal. I found that the targets that you mentioned are quite interesting to debate, and I think that in the end, we need to collect the right eggs to do some omelets, and that's the most important aspect, is to actually be able to monitor that. But I think most of the questions have already been done. I wanted to speak about the importance of having these lived experiences in your work. So you mentioned that the focus groups are quite important to develop these targets and these initiatives. And also at the same time, you mentioned that it's a very important action to have corporates and governments reporting these numbers and actually be engaged as well. So my question is, how can we bring these lived experiences to the table, but not only on the WHO side, but also on the government and the corporate side as well? That's the question. Thank you.
Yeah, thank you. It's a great question. I'd be happy to answer it. So right now, we are in the process of applying all of that learning that we have conducted over the past 2 years towards the development of what's called the WHO framework on the meaningful engagement of people with lived experience of non-communicable diseases and mental health conditions. If you can repeat that back to me, I'll take you out to lunch. But this framework is essentially a summary of all that valuable lived experience that we've acquired. I want to emphasize that it's not just related to diabetes. In fact, we are tackling a lot of different disease categories within that framework. We are in the final stages of editing it, and it should be released hopefully in Q1 of 2023. So what does that mean in terms of the application? It means that the primary audience for that are member states and government entities, right? So what we're doing is we're bridging the gap between the lived experience perspective and the policymakers, and hoping that the policymakers will actually adapt and implement a lot of those findings within that framework within the regions. So that is the goal, that's the intention. It's actually very exciting. The lived experience approach is actually quite novel in the broad scheme of WHO. It's something new. And so we're also learning along the way, but it's really driving, I think, at least from the team that I'm specifically supporting, a lot of the efforts. So hopefully that will be released soon. You'll be able to read it. You can share it with whoever you'd like, and hopefully the next stage will then be an implementation phase, testing that out in different pilot countries. So,
I'm Fatih from Maldives. So 2030 is about 8 years from now. So my question is, how far have we reached in terms of achieving the target?
Thanks a lot for the question. I think I received this in the beginning as well, where the question was like, what is the baseline that we were working out from? Like, to be honest, these targets, they were endorsed or agreed in May this year. So it's only like 7 months ago that we knew that we had to work for these targets, but we have initiated different work to both achieve the targets, but also to monitor the targets. And the global monitoring framework, we plan to have it ready during next year, which will guide member states on how to do monitoring of the global diabetes coverage targets.
Any more questions? No?
Thank you for the questions and for the answers. I think were very important for us to understand better this global scenario and the Global Diabetes Compact and the targets. Well, I believe that what would be interesting also for the young leaders would be to hear a little from you. So some advices of, to have a global career, so to be a global advocate. I think that would be wonderful. Thank you.
I think we should let Ida and James, who almost have been young leaders themselves, or been at least...
Sure, I'd be happy to answer that. But I'm actually curious to learn more about you guys, because one thing that will help me answer this question is, for all of you out there, how many of you decide that this was going to be, that you were going to be an advocate, that you were going to be a person that was going to be a champion in your community? Or are you here because it's just happened to you? Someone said, you'd be really great at this. So was it part of your plan, this is my question, to be a young leader or to be an advocate? Raise your hand if it's a yes. Okay, that's about a little more than half the room. Or raise your hand if it's a no. Okay, so for me, the answer was no. I had no plans in this career. In fact, when I was diagnosed when I was 4 years old, I was an immigrant from Iran to Los Angeles. My mother didn't speak any English, and when I was diagnosed, she didn't even understand what was happening to me, and I had to be a translator at the age of 4 in this condition. So it was very, very tough. This was a time where there was no internet access, there was no Instagram, there was no IDF, no Young Leaders Program. But what I knew very on in my life was that I knew the world to be a very small place. I had a fascination with the flags of the countries and began studying them and learning languages when I was very young. And I thought, you know, maybe I'd make a great doctor. Maybe that's what I want to do, right? Maybe that's the way to save a life. But I realized that there's lots of different ways to save lives. And in fact, advocacy, I didn't choose it. It kind of chose me. When you live with a very multifaceted and difficult condition like type 1, you guys know this very well, or any form of diabetes, sometimes that burden of advocacy falls on your shoulders without your wanting it to be there, right? And so I wanted to be a doctor. I also wanted to be a professional tennis player, and none of that happened, right? So, yeah. So my interest in this primarily came from my interest in the world. It was an interest in preventative health, and I think the timing for my work at WHO was right. I fell into WHO later in life. I did pursue a graduate degree in public health, in global health. But again, the timing of that degree was not quite right for me because I was still so busy just trying to survive every day, like all of you, right? So it's a lot to think about. But I think my advice would be to never underestimate the power of your own advocacy and your own work. Advocacy is a very broad field. You can go in 1,000 different directions with this. And so whether you decide to pursue this ultimately as a career track or not, you will know. But your voices are very important. I've learned that too. So if your interest, if your passion is truly in this space, then really find the area that means the most to you, that you connect with the most, not the one where you feel the most pressure to be that voice or that representative. And I think that's the way to really, save the lives that you're already saving and impacting. So yeah, I'm here almost by accident. And I remember the last thing I'll share, because I love storytelling, is I mentioned I was diagnosed when I was 4, but I did not meet another human being with type 1 diabetes until I was 25. And it was by accident. I was walking down the street and I saw a person wearing an insulin pump. I saw their pump and I ran up to them. I just ran. And I said, hi. And they were like, who are you? What do you want? And I said, I noticed you're wearing a pump. I wear one too. And it was the first time that I could say that out loud. I did not live in a world in which, or a culture in which, the experience of disease was something to share, right? So that's that. But that's why I'm here, because I think this community is very different. In fact, of all the work that we've done in meaningful engagement, the diabetes community, they're the loudest voices. And so I want to ask you to think about this question when you leave today. Why are we the loudest voices in this space? What is it about this experience that makes us the loudest voices? And think about that when you take your next steps, when you journey on, whatever that is for you. So, yeah, that's it. James, go for it.
All right. Well, mine's going to be
Tino has a question, maybe.
Yeah, go ahead, Tino. Tough act to follow.
Yeah, it's a very touching act.
Okay, thank you. I didn't want to ask a question, but I think this is a crazy question, so it's coming last. Right. So, okay. So you mentioned you're always talking about members. You'll be like World Health Organization having to help its member state, people that are part of it, right? So we are talking of global commitments, right? So like I was thinking maybe if we are saying 100%, that means everyone needs to be involved, everyone, like sort of like no member states, but the world at large, right? That kind of a thing. So I don't know, when you have this World Health Assembly, I don't know if you also involve people from the pharma, the big pharma. Are they in agreement with it? Like when you're sharing these things, I mean, there are so many people that are involved. And are all the world leaders involved in this, or just your member states? I don't know, like, who are the people that have to be part of the World Health Assembly to have these things? Like when you're discussing these things, I don't know. So, I mean, that's a crazy question that I had.
No, thanks a lot for the question. It's not crazy at all. I think and I actually think, Beatrice, you're here, right? You usually attend the EB and the World Health Assembly as well. But the thing is that it's when we have these resolutions or agreements, it's not the farmer, it's the member states, and the member states, they have a delegate that they send to this meeting, and then the World Health Organization, they have their leadership there as well. So it's not like the farmer is a part of the meeting or decide the agenda, if that was what the question was. But actually a lot of people are in Geneva at that time usually. I know, Beatrice, and maybe you can tell some of the things that you're doing when you're there, because a lot of activities happens outside, but the discussion itself about the targets and the resolution, it's not involving like pharma or industries. It's the member states and the World Health Organization that have these discussions.
And they're broadcasted now.
Yeah, it's broadcasted.
So you can actually see it with translations. Yeah. And it's quite funny because I'm going to get in trouble for this, but just your question from Cuba made me think of sometimes the member states don't like each other, and they make that very clear in the discussion.
And I think maybe it could be funny for you, Tino, if Beatrice, if you could say what your role is when you're there, because you do some advocacy, I assume.
Yeah, some advocacy. Yeah, it's a bit what we were saying before, guys. So there are a lot of international commitments. These are political discussions that member states, so governments are having. As James is saying, some countries do not like each other. They may vote differently on some things, but this is a discussion that is happening at the global level, but there is no global policy to change things. That needs to happen at the national level. There is not a global policy on diabetes. That has to be a global policy in Zimbabwe, in Uganda, in Lebanon, in any other country. So that's where you play a role. The governments need to do their part, but you also as advocates have the responsibility to speak up for you and for the rest of the people living with the condition. I was telling you about this platform that we have in the IDF website to send letters to the prime ministers of your countries about diabetes education. So those letters are not only sent to the prime ministers, they are also sent to the permanent representation in Geneva. So most of the countries have, let's say, an embassy, a permanent representation in Geneva, because in Geneva there are many international bodies, including the World Health Organization. So depending on how big the country is, it's going to be a tiny office, maybe 1 or 2 people, or it's going to be a huge office with 50, 100 people. If the office is big enough, there is going to be 1 health attaché, sometimes even more, and that person is going to be responsible for all health issues. You can reach out as citizens of your countries. You have the right to reach out to those people. Not only to the people, let's say to the Prime Minister, to the Minister of Health, etc., but also to the people who are representing you and your countries in Geneva. So we as IDF do that, but obviously we do that representing the whole diabetes community. You, as citizens of your countries, have the right, they need to listen to you because they are there actually to serve you. So that's one thing that you really need to play with, because that's super important for the advocacy work that you will be developing.
Did it help, Tino? I think Beatrice, she's much better at telling what happens behind the scene.
I'm just speaking from the other side, yeah.
Yeah, perfect. And then I think James also could.
Yeah, maybe I'll be a bit just specific about. I mean, like Ida, I was diagnosed at 12, I think. I come from a small town in Canada, about 2.5 hours away from anywhere. And I don't think anyone in my family knows what the WHO is, or the UN. And but I did know pretty early on I wanted to do something about diabetes. And you finish your high school or gymnasium, and then you get into your undergrad. So I did a biomedical science degree, which in Canada is kind of like pre-medicine. And you get in and you're thinking, well, maybe I'll be a doctor. But then I was thinking, well, I don't think I would survive 100 hours on residency. And I'd be a mediocre doctor, and I started getting into more of like healthcare policy and more on the structural side of healthcare systems, and I was very good at it. So I figured, okay, well, I'll try to get into something like that. And I went, I went to apply to a bunch of colleges in Canada and got rejected. I applied to Karolinska Institute, which has a Nobel Prize, and they let me in. So I went there, and I met people from all over the world. I think most of the class was not Swedish. I had 35 classmates who I still keep in touch with. And I ended up going to Oman, so people here in the Middle East, that's why I speak Shway Arabi. I did a project in Oman. So Oman was an interesting country because it's the most rapidly developed country in the world. It went from having like one hospital and one paved road to basically being like Houston, Texas in like 30 years because of all the oil money and change in government. But because of that, it led to a lot of epidemiological transition, a lot of problems with diabetes. And then I just kind of kept on bouncing from place to place whenever I see interesting work. So I went to basically a health region in Canada for a year. I went to kind of the Canadian equivalent of NICE, like the national, we didn't call it that, but it was like a clinical evaluative place. Ministry of Health after that, and I started freelancing. So I did work for Diabetes Canada. I did 2 missions with Doctors Without Borders, Médecins Sans Frontières, in which case I started getting more involved with like fellow diabetes advocates, especially through social media. Became very good friends with Elizabeth Feister, who was actually a young leader herself and was the founder of T International. I was a founding board member along with her husband and a couple other people. And so you might remember the Insulin for All campaign. But all of that was basically not getting paid. So I think it's only been about a year since I joined the WHO where I'm actually getting paid for my diabetes work. So the caution there is like, yeah, don't go into advocacy to get rich. It's not the way to do that. But specifically for global health, there's more than just the WHO. So like the WHO, I mean, I'll be frank, we're probably going to have more diabetes positions opening. But every time we open up a diabetes position, there's 500 people who apply, and the competition's very stiff. But you're still welcome to apply. And the other thing is, people in this room, if you live with diabetes and you go into a discussion about diabetes, chances are your technical knowledge is going to be much better than the mean. Like, it's amazing. You know, you've probably been on conversations about diabetes and you get in and there's so-called experts who don't know the difference between type 1 and type 2, they don't know the difference between a long-acting and, you know, so you already are imbued with a lot of technical knowledge, and that's very competitive. And if we get our way at the WHO, the Global Diabetes Compact, and just people living with diabetes in general, we're going to try to get more opportunities for diabetes, we're going to try to get more need for technical knowledge. But again, it's not just the WHO. People here at this conference, we have people from FIND. It's an interesting organization based in Geneva that's doing work on diagnostics. We have people from Medicine Patent Pool. They do interesting work on what's called voluntary licensing. Look at the members of the Global Diabetes Compact Forum. And I guess finally, make friends with each other. Like the young leaders and other colleagues, I was never a young leader, but I know of the young leaders, they still keep in touch with each other. They, you know, send each other happy birthdays, but they also say, you know, have you seen this posting? Or can you give me a reference letter? Or I'm gonna be in your city, can I crash on your couch? Like that's very much how you get ahead in this industry, because it's a small industry. Like, you know, like our boss Slim, I've known Slim for like 8 or 9 years. When we were at MSF together, he was a board member, and that's why I went to Lebanon. He saw work I did in Oman and was like, do you want to go to Lebanon and just repeat that study? And I said yes. So that's what I did. And then, you know, I still kind of kept in touch with Slim, but like here I am like 9 years later working, you know, under him. So don't make enemies, make friends, and realize that you have power and that you have your own technical knowledge, which is actually a lot more advanced than you might give yourself credit for.
I see we have a question, yeah?
Hi. Hi? Okay. Hi, I'm Julia from Portugal, and I have one question. So, over the last few months, I have done some research in the perspectives that Portuguese type 1 diabetics have about the disease. And we know the numbers of the people with type 1 diabetes globally, but at the local levels and the regional levels, we don't know what are the numbers. And my question is, as a young leader in diabetes, what we can do to find out these numbers, because in my perspective, I think that to advocate for people, it's very important to know the exact numbers, because the numbers impact the policy, impact the all of the policies that we can do.
Yeah, thanks a lot. Yes, and actually, I don't know if IDF, they have some data. I think they have for young people type 1 diabetes, but we published an article a few years ago where we have country data as well on the prevalence of type 1 diabetes in all countries, and not only children. It's Gren, he's called Anders Gren, who's the first author, and David Baran and Goika Roglic are also a part of it, but there we actually have data at country level as well, not only for young people, but also for adults with type 1 diabetes. So maybe it's worth looking up if that's what you're looking for. But to be honest, it's not from region to region, or it's only at the country level.
Okay, thank you very much.
Well, thank you very much. It was a wonderful session. And we will...
Can I ask one last question?
Yeah, one last question.
Okay, I'm making this question under my capacity as a young leader and not part of the IDF Executive Office. So, thanks, the three of you, and especially Ida and James. I think means a lot to us to have people living with the same condition as us that have managed to build their careers, their paths to ended up where you are. Yesterday, we had a lot of conversations, discussions, comments about respecting our own limits, respecting our own boundaries, like how far should we go when it comes to advocating and working and relying financially on a condition that we live on 24/7. So based on your own experience, if you don't mind sharing really briefly, like any type of tip or wise advice, how we can, you know exactly what I'm talking about.
Yeah,
yeah. Thank you.
I don't.
Well, I think the fundamental aspect of advocacy is to advocate for yourself. So if there are opportunities that come across your laps that you're interested in, don't be afraid to ask for compensation. Don't be afraid to ask for a stipend. And if the answer is no, then the answer is no, and you have to make the decision for yourself whether that's a good use of your time. The other thing I would suggest about boundaries, and this is something I've experienced because I avoided diabetes advocacy intentionally. I wanted nothing to do with it because of that boundary. However, you can be magnificent advocates as an artist, as a musician, as a lawyer, as an engineer. Well, I don't know about an engineer, but a doctor, right? There's lots of different ways to feel rewarded for that advocacy that also satisfies you financially and personally. One of the biggest feedback areas that we've received from this lived experience work is we don't get paid for this. No one gets paid for the advocacy that you do, and you're really doing life-changing work, and that is ultimately not fair. And so that is a recommendation and a finding that we're also taking forward in this framework that we hope people will listen to. So advocate for yourselves first. That's my advice. So before you feel the pressure of needing to advocate for others. Yeah, I'll stop there. I need to think about it a little bit more. But James, go for it.
Yeah, I very much agree with that. And Bruno, I know you're an advocate. You've been in this for a while. This is going to be a weird detour, but I'm remembering a master's course I did back in Sweden, and it was a guy who used to work for UNICEF. And he was basically saying, like, if you're on a field mission and, there's someone on your team who says, well, we can push through that minefield and we can deliver all that food and we'll save all these babies, don't do it. Because if you're dead, you're not going to do anything else after that, right? The same thing, like, if you're worried about your mental health, if you're not in a good state to advocate for other people, you're not in a good state to, do direct aid, you need to pull back, because if you're not in a good state, if you're endangering your own life, there's not going to be any advocacy after that. So advocacy is very much a marathon. You're not sprinting to something. You need to do advocacy at a state that you can continue to do it for the rest of your life. You don't necessarily need to like burn yourself out. And you get into these states because, you know, you might meet with a minister and you might be a very good meeting and you say, now this momentum, now we can do that. But you need to know yourself and know your own limits. And there's nothing wrong with taking a break. And there's nothing wrong with, you know, what you're feeling is normal. I think, especially with TO International, but I also know like the people who do mutual aid diabetes. And people get into mutual aid, and especially in America, you know, and you meet people in parking lots or you hear stories and you hear like human suffering. And that, if for most people, for 99% of people who have empathy, that is tremendously difficult. And, you know, people make their living in social work to do that, but especially if you're doing that as a volunteer, especially if you're doing that as a disabled person. So you need to set your own limit, and there's nothing wrong with taking a break. But that being said, you have to find joy in it. So you have to also find joy, like, in the work. Like, you know, I'm not going to say I would do this job for free, but I do like the work. It's very good, and like, you have to get into a position to like do work and do advocacy and actually find joy in that advocacy, in that work. But again, we don't mind if you ask many of us to attend focus groups. If anything, it strengthens our hand because we think it probably should be done. But oftentimes the person you're talking to is dealing with institutional rules. But if you don't raise it, no one else will. That is basically just take care of yourselves and take a marathon mentality.